One question I have for our panel is, who else has had any experience with using lithoplasty for these heavily calcified lesions, and what your experience has been?
Yeah, we've been very fortunate that we've had lithotripsy available in our lab now for 2 years. We've literally done hundreds of cases, and in my mind has been, and I know this sounds somewhat dramatic, but the single most important breakthrough in the vascular space in the last 5 to 10 years. I mean, it has completely changed the way that I treat calcific disease in multiple vascular beds. We've had 0 cases of distal embolization, we've had 0 perforations, and it really makes the procedure be very safe and very predictable. I can tell you that the company is working on an 8mm diameter by 3 centimeter lithotripsy balloon, which I think is going to have great utility, particularly for these calcified iliac arteries, but also for mesenteric vessels, common carotid arteries, subclavians, innominate vessels. So that will be a very welcome addition to our therapeutic armamentarium. We have had cases of horrific aortoiliac disease and distal aortic stenotic disease that we've referred to a vascular surgery, and they just said, you know, these vessels are just too calcified, we can't do anything with them. And we've actually done kissing shockwave balloons to treat iliac disease, and with remarkably good results. And these, you know, these are hard but also fragile vessels. So being able to prep those vessels adequately has really, I think, allowed us to get these vessels open in a very safe and predictable manner.
Great, thank you. Anybody else?
Use it about 5-6 times. I think in those rock-hard calcified lesions in the FemPop or in the iliac, it's really been helpful to help your stent expansion. But the cost finally caught up to us, so we have to wait a little bit now.
Sure. Great. Thank you for that presentation. I have a question for Dr. Titus again. Some members of our audience may not be as familiar with EVAR and aneurysm repair, but are faced with an iliac stenosis and calcified tortuous iliac arteries and are considering an endovascular repair. What do you wish they would keep in mind as they proceed with an endovascular repair with an aneurysm that will likely someday need an endovascular repair?
I think the biggest thing is stent sizing. There's nothing more frustrating than getting an aneurysm referred to you, or you're seeing one who's had iliac stents before, and common iliac stents of 6 millimeters. That makes no sense. I never go smaller than 8, and I usually try to go 9. I use covereds for the iliacs, and I think that gives you more options to be more bold about dilating more. As far as other considerations is, I would say bringing the stent down past the inguinal ligament is also very frustrating, you know, when you're trying to get devices in, because they tend to get stuck there or they ruin your access site. But those are kind of my main considerations I can think of.
Great. Are there any other comments about that?
You know, I think if you have a significant aortoiliac occlusive disease combined with aneurysm disease, unless the aneurysm is very small, you should just fix it all in one stage, would be my inclination, even if it's a 4 centimeter aneurysm. To leave the aneurysm behind and then just treat the occlusion, you're just setting yourself up for problems in the future.
I would agree with that. I think the ones we see downstream, though, are you have like a 4.2 centimeter aneurysm in a female with common iliac occlusions, you know, and people are trying to decide what to do. And I don't think would you fix the aneurysm at that time at 4.2? I think you'd have a hard time reimbursing for it.
No, I mean, I think you could put, especially if she's a good EVAR candidate, I think I would fix that at the same time. Fix the whole disease segment. The aorta is disease. So I think if you just treat the occlusion, especially if it extends into the aneurysm, you're really setting yourself up for a difficult repair in the future.
You simply have to acknowledge that sometimes you can't ignore the aneurysm. We'll have to repair it at the same time and just have that discussion with the patient. If we don't fix it now, it's going to be harder to fix it later. And I found that 9 out of 10 patients will agree with that.
I have a question for Dr. Soga.
Yeah.
I must say I was a little bit surprised and your pictures were so nice with the aortic reconstruction where you put the self-expanding stents and left with very kind of small channels, and then your follow-ups at a month and thereafter were impressive that it actually self-expanded that way. I guess what's been your experience to date? How much do you expect it to self-expand? And do you try, when you're ballooning them up, do you go to burst pressures or you under-dilate them? Just if you can expand on that a little bit more.
Yeah, well, so in Japan, so large diameter stent is not available as well as a covered stent. Therefore, so other times, so one other technique of the endovascular procedure, I put a double lumen stent placement. But so after the successful stent placement for the aorta or the two self-expandable stent, if you can do the fully dilated of the self-expandable stent, there are some safety concerns such as the distal emboli or the vessel rupture. Therefore, so we wait for the dilation of the self-expandable gradually. Then, so we succeeded that. So, so from the take-home, my message is a self-expandable stent is a very safe and useful in the chronic phase. So you can put the successful initial result. Therefore, so the angiographic optimal result is not needed for the aortic occlusion if we put the self-expandable stent. I think that's that.
Have you ever had any of them thrombose off shortly post-procedurally?
Sorry, that?
Have you ever had any of those thrombose off post-procedurally or shortly after?
No. Yeah.
Also, a follow-up, Dr. Do you always do angiographic follow-up on these? It seems like a lot of your follow-ups were all angiograms. Is that how you do it?
So I do not routinely angiographic follow-up, but sometimes I'm very interested in the chronic patency. Therefore, so collaborate with the patients. I check the angiographic result. Sometimes we routinely CT angiography, but it's not different from the angiographic result. Therefore, sometimes I check the angio.
I have a question for Dr. Trinidad. So in my practice, I'll occasionally see a patient who has kind of got a subacute occlusion of an iliac, and you know, the wire just sails through, and you know it's going to be a setup for embolization. So what are some things to keep in mind for these subacute occlusions in treating them endovascularly to stay out of trouble with distal embolization?
Well, somebody like that, I would perhaps use IVUS to give myself an idea of the morphology of that thrombus, and if, when possible, put a filter in place and really not start doing anything until the ACT is adequate, 250 or more. And the one thing I learned the hard way is if the patient's under anesthesia, I will not wake them up until I've checked the feet and make sure everything's fine. I found myself in the situation where, like, we're done, everything went great, and then the nurse is checking the pulses and they're not there, and so you have to go back. But I think that's about all you can do.
I don't know if there's any other comments about that, or maybe managing coexistent iliac aneurysmal disease as you're fixing an iliac stenosis. Covered stents and, you know, of course, a cut down is the best sort of embolic protection, I guess, but that's not available everywhere. But what other embolic protection tips and tricks might be helpful?
Well, you know, one of the things, if you IVUS, and I think I'm in agreement with IVUS, said to all those lesions, you know, you see a lot of stuff that you don't normally see with an angiogram. I mean, if you see a lot of thrombus, it doesn't hurt, you know, to have this embolic protection, you know, device downstream, but try to take some of that thrombus out. You know, try to use, you know, some angiojet system or whatever you need to do to try to clean that soft thrombotic material, you know, out of the way. Covered stent probably will be the standard in that case, you know, if you're really worried about a lot of embolization. And these are big chunk of thrombus. Even when you put the filters, we've seen filters completely overwhelmed, and really becomes very tough to pull those filters out.
So to follow up on that, if you see a particularly thrombotic lesion that's, let's say it's fairly focal, how far distal do you extend that covered stent to ensure you capture all that crud behind the stent?
Yeah, this is a great question because, you know, once you dilate into that thrombotic lesions, you can expect that that thrombus is going to expand to the edges. So I would almost routinely, you know, almost 1 to 2 centimeter beyond that lesion on both sides if I can.
Mm-hmm. I think you just have to keep in mind, I think, to be careful where it's getting up towards the renals, because you can easily toothpaste that up into the renals. So I think those patients maybe that's a good scenario to have a multidisciplinary kind of discussion about the best approach before we kind of get ourselves into trouble with the renals.
I agree with Karim, and I think one tool too, especially for aortic occlusions that you think have any subacute component or you fly through, is sometimes just overnight lysis. Just drip it in, see what they look like in the morning. If the feet change and you're worried about them, then you can be prepared with general anesthesia. Do a small femoral cut down to flush out if you think you're going to pull out a bunch of junk. But overnight lysis tends to be a tool that I think is very useful when you think you have any element of acute thrombus burden.
I think this goes along with, you know, a lot of us, or some of us are doing, for claudicants and disease in the SFA, where sometimes if the wire goes fairly easily, we're doing some penumbra suction, even in the FEMPOP area. We're finding that the true lesion is a lot smaller than what we're seeing on angiogram. So for the iliac as well, in those situations, what I would consider is I'd put a short Craig-Mack infusion and just pulse spray for about 10 minutes, TPA, and then suck it out and then go from there. Okay. That you can do same-day treatment, and you might find that the disease is much less.
Great. Well, I think that we're right on time. We've got one question. Dr. Shishabor.
More of an announcement. I'm sorry.
Oh, excellent. We love announcements here.
And this is a good announcement, I think, in my opinion. It's a faculty and all attendee reception tonight at 9 p.m. in the former Saint restaurant on the first floor at 9 p.m. We look forward to seeing everybody. There will be drinks and hors d'oeuvres and food and stuff like that. And dancing? Live band. And live band and dancing, so
wow.
Please bring your dancing shoes.
This meeting just keeps getting better and better. All right, well, thank you to the panel. Thank you to the audience for attending this session.